To Las Vegas. We're thrilled to be here ourselves. I've got an esteemed panel with me, and we'll be addressing these issues. And as we were preparing, I will tell you what's fascinating about this group is they all come at the disease from different vantage points. And we're going to have a very interesting conversation today about not just the dynamics, but we're also trying to uncover best practices and a few ideas that we can all follow going forward. One question I have, just to understand the audience a little more, how many of you are clinicians? Okay, we got a few. And then healthcare providers, working for a hospital, okay. And then investors in digital health, not so much. And health plans, payers. Great, okay, terrific. So with that, I'm going to introduce our panel. I'll just say, as I do in a moment with them, that we've all seen the numbers on diabetes, 38 million currently in the US with diabetes, and then another 98. We term it pre-diabetic, but as Dr. Gutman has apprised me, it's not really pre, because you are either a diabetic or you're not. Anyway, but the point is that 8 out of 10 of those people don't even know that they have the risks. And so from my perspective, this is where the core of the work is that we need to do. And so with that, I'm going to introduce, starting with Dr. Amy Gutman, talk with the group a little bit about yourself and your focus on and what your company, Tough Love Med, does.
Good morning. So my name's Amy Gutman. I am an emergency physician from Orlando, Florida, where it is a lot warmer than it is right here right now. And I have a private company, Tough Love MD, in that it is all the things I don't do in the emergency department. And it came out of me becoming very, very ill and not being able to fix myself, and then realizing 85% of the patients I take care of at night, and I only work night shifts in the emergency department, a little bit crazy, but about 85% have chronic disease, and they're there because of their chronic disease, which is absolutely preventable. I will happily have a gunshot wound to the chest every night, other than telling a 21-year-old diabetic, guess what, you've just had a major stroke, and you're in kidney failure, and you could have fixed that. So I spend a lot of time outside of the emergency department talking to everybody, but a lot of executive leaders as well, for their company's health, how to keep them healthy, everybody metabolically well for their body and their mind. That's Tough Love MD, and I'm very happy to be on this really interesting panel today.
Thank you very much.
Just talk into it.
Okay, not quite.
Seemed to work.
Did it work? Oh, there you go. Okay. Next we have is Dr. Adam Perlman with Pendulum Therapeutics. You want to? Just an intro is good. Yeah.
Okay. Sorry. Gotta get the right program. Get with the program here. So thank you. Yeah, thrilled to be here. Adam Perlman. I'm an internal medicine physician by training, but I've done integrative and what's called functional medicine for 26 years. A little more of the holistic health, but typically within academic health centers. So I ran the health and wellness portfolio for Duke University, the Duke Diet Center, and Fitness Center. So I do a lot of lifestyle medicine as well. Most recently, I was at Mayo Clinic in Jacksonville, Florida, and including having a role as medical director for employee well-being. So I thought a lot about preventing diabetes and reversing diabetes whenever possible. Until about a year ago, I have a particular interest in the microbiome, the 100 trillion bacteria that live in our gut that influence pretty much every aspect of our health. This is sort of an evolving area of science, and was doing some research on type 2 diabetes and the microbiome for a company called Pendulum Therapeutics, which is a biotech company based out of Silicon Valley that's focused on the connection between the microbiome and human health, and have a probiotic blend that actually influences and has been studied in type 2 diabetics. And as a part of doing that research, sort of fell in love with the company. The chief medical officer decided to retire, so as of a year ago, I am chief medical officer for Pendulum, still based in Jacksonville, Florida, where I was at Mayo Clinic. So thrilled to be here and looking forward to the discussion.
Thanks, Adam. And then Arcella Burton, she's Vice President of Government Affairs at HealthX, very interesting health information exchange technology outside New York.
Hello, I'm happy to be here today. Tell you a little about myself and our company. HealthX is a health information exchange company, the largest in New York State. We have over 20 million patients that we collect data on. And what we're doing for diabetes and for all cohorts of diseases, but primarily for diabetes right now, is that we have a new program called Focus 360. So we collect all your health data from your doctors, even if you go to your nutritionist, your labs, your radiology, and we will send alerts to the doctor to let them know what your A1C is. If there's a change in your metabolic panel, we notify the doctor with an alert that let them know that. We also like to give the patient that information too. So we have an app for the patient called My Health Record New York. It's free for all New Yorkers, and it's a way for them to see what their numbers are. So when they're talking to their doctor, they can say, you know what, I don't understand why my numbers are so high today. I ate what I was supposed to eat. Do you know why it's high? So we're trying to empower patients to talk about their own diseases too. Thank you.
Great, thank you. And also with us is Dr. Bitlab Malo, who's with founder and CEO of an organization called STAPGen.
Hello, everybody. Good morning, and thanks for coming here. Thank you, Health 2.0. To inviting us in this, so distinguished panel. I'm a dentist by profession. I've been practicing dentistry for 25 years. And 3 years ago, I started the company called STAPGen with a mission to prevent type 2 diabetes and see a world without diabetes. We developed a test that will predict your type 2 diabetes 5 years in advance, and we can recommend what step needs to be done. And the next, we also developed a therapeutic. If you need it, we can supply it. And we have the test and we have the medicine. We need your help to implement it. Thank you.
Thank you very much. Also, we have another panelist who was not able to join us this morning. She will be around later. Her name is Dr. Isa Chalamet. She's from San Francisco, and she is the CEO of an organization called Yoga of Health. Without going into too much detail, her focus is really on the health of the liver and how we have to make sure we pay attention to that and keep it strong and clean, because it relates also in some ways to the whole health of the microbiome and the gut. So she will, I'll speak a little bit at various points, but I'm also going to have Bitlab do some interjections too, because some of the things that he does around cleaning toxins relates to some of what she does. So I thought what we could do to start the conversation is just have a high-level brief about the dynamics of how diabetes gets how we get conditioned with diabetes and get sick. I thought that having a grounding of that might help us kind of establish a framework for the remediation plans that we're talking about. Because we know diet and exercise is important, but, and I'll ask each of you this question: is there a particular point of attack that you each must feel is prioritized for someone to reduce their risk? Is there something in the way you would prioritize that? I'll start with maybe Amy.
Sure. So, like all chronic disease, it sort of comes down to the fact that, especially with diabetes, inflammation, so insulin resistance, which is sort of the condition of When your sugars are out of control for whatever reason, whether you're born that way or it's acquired over your life, as most people who have type 2 diabetes. So chronic inflammation leads to insulin resistance. You have more and more sugar, and your pancreas just can't keep up. And the gut biome, which tends to react very poorly to chronic inflammation. So if you can attack, for whatever mechanism, not necessarily pharmaceuticals, not necessarily this particular product, not necessarily this specific, but if you can attack the insulin resistance at a root cause, and with functional medicine, it's the attack as well, if you can address the root cause, you make the chronic disease go away. That way you don't have to worry about a million different individual therapies, just the root causes. For me, it makes sense for ketogenics because it's a low carbohydrate approach. And if you take a diabetic and you put them on a low carbohydrate diet and take away the thing that's killing them, they tend to react very well to that because you don't need carbohydrates to survive. Fixes the gut, fixes the liver. You don't have to be on Ozempic the rest of your life, having diarrhea at weird points during your day, or bowel surgery, or going blind, all these wonderful things. But I'm a root cause kind of person.
That's great. Adam, anything you want to add to that? Because we talked about inflammation as well.
Yes. Well, what's neat about a panel like this is I think we're all bringing a different perspective. I think each one of us, and easy to sit here and say we need to eat better and exercise and all those sorts of things. I mean, at a very core level, building on what was being said, the issue is really, if food is energy, and it's really energy overload, and when the body doesn't know what to do with that energy, it stores it, and that creates issues with our metabolic health and insulin resistance and things you were just hearing about, and ultimately diabetes. And socioeconomic factors come into play, and you'll be hearing, I'm sure, more about that. I think the angle that maybe I would bring, just to sort of clarify, is I think what's really interesting in terms of the science is we're beginning to understand from a methodology perspective or a pathophysiology perspective kind of what is happening. So I know we were in a discussion earlier and we were talking about childhood diabetes, and which is obviously driven in parallel with childhood obesity rates. But and one of the comments that you made was, well, a big part of that is that people eat so much ultra-processed foods. And I think we all kind of accept that now, right? Okay, if we're eating a lot of ultra-processed foods, it's going to create havoc. Now we're beginning to understand the pathophysiology there, or what is going on. And so I'll try to do this in another minute.
No, that's good.
But a lot of it has to do with, and again, not to sound like a one-trick pony, we need to eat better, exercise, all the things that we need to do, but just to focus in on this one area for a moment, a lot of it does have to do with the impact on the microbiome. And so let me use GLP-1 as an example, okay? I know there was only maybe a smattering of clinicians here, so maybe if I said, what is the drug Repatha, some of you may say, well, I've never heard of it, I don't know. But if I said to you, what is the drug Wegovy? How many of you have heard of that drug? Or Ozempic? I'm sure the majority of the hands, unless you just don't watch TV anymore, would probably even know the jingles, or some of the other ones that are out there. And so what's happening right now? Well, what is Ozempic and Wegovy? I've spoken to many patients on those drugs that don't even realize that that is a synthetic form of a hormone that our body releases naturally called GLP-1. And certainly these drugs have an important role to play. They are very efficacious. We don't have a lot of long-term data. They certainly have side effects. That's something we were discussing. And I think equally as concerning, what's the long-term plan? I had a friend of mine who was 53, wanted to lose 15 pounds, got a doctor to write him for Ozempic, but then what's the plan? Is he going to stay on Ozempic for the next 40, 50 years of his life? Because we know as you come off it, typically, the weight goes back on. So I'll try to be brief and explain that the way it normally works in the body is that you eat a meal, that many of us just did, and it's actually the bacteria in our gut, certain strains like something called Akkermansia, there's no quiz at the end, but these what are called next generation strains, meaning it's not the typical Bifidobacterium lactobacillus that we kind of grew up with that would be in a probiotic, but strains that they are newly being discovered and that have a profound effect on our health. They actually eat that meal. and they release signaling molecules that then bind to receptors on cells that line the gut in response to that meal, and that triggers the release of GLP-1. And then this GLP-1 hormone goes to your pancreas, tells your pancreas, you just ate, make insulin so your blood sugar doesn't go too high. Goes to your stomach, slows down your digestion, allows you to absorb your nutrients and feel more full, and then travels up your brain to the areas of your brain that control things like satiety, feeling full, and tells you to feel full and stop eating, right? Shut off the valve because you've had enough. The problem is that there's so much that we do, like eating ultra-processed food or not getting enough sleep or not exercising enough, or even things like I just did, traveling from the East Coast here, where you have changes in time zones and circadian rhythms. All of this can disrupt the microbiome in a way that we can be deficient in these key strains that are that middle person that allows you to release GLP-1 effectively. And this is at least part of what's driving, mechanistically, a lot of the sort of the epidemic that we're seeing in the rise of things like insulin resistance and diabetes.
That's a great clarification of the process. I actually, Ursula, might pass over you to go to BIPLAB because you're talking about toxins and how and where they play a role, and even to the degree that Dr. Chalamet talks about the liver. Maybe you can speak to the toxins and stuff as well.
Okay, sure. I'll try. Now, on these panels mention that microbiome, yes, it does play a very big role. Now, there is an enzyme in your gut that takes care of the microbiome. I want to mention it because probably this is the most important enzyme in your entire life. Okay, and I mean it. Today, how many of you brush? Everybody. So who brush our gut? Okay, it's very simple. We found that it is in the intestinal alkaline phosphatase. So what happens? All the dead bacteria have cells and they produce toxins. And intestinal alkaline phosphatase detoxify the toxins. In a person who is healthy, it is a normal process. But in a person who does not have that intestinal alkaline phosphatase, it becomes a problem because you cannot detoxify those toxins anymore, and they go to the blood. Anywhere they go, they create the problem. Liver is one of the organs, kidney another. They keep us safe from different types of toxins, and that's the detoxifying the liver comes. Now, our solution, very simple. It is based on discovery by my brother. He has been studying this. His name is Dr. Madhusudan Malo, MS Malo. In 2010, he and his colleague found a very interesting that intestinal alkaline phosphatase measures intestinal alkaline phosphatase maintains the homeostasis of microbiome, and it was published in 2010. Now 2015, 15 years ago. What happens that if you have low level of IAP, you develop a called intestinal alkaline phosphatase deficiency. The STAP test, stool alkaline phosphatase test, measures how much IAP unit you have in that stool. If you have less than 65 unit per gram of stool, we consider that's IAPD. And that is the risk point. Then if you have less and less, that means you develop even more problem. So we detect and quantify and measure intestinal alkaline phosphatase, very simple, with a step test. And then, according to the risk level, we'll be prescribing if at all you need a next step or not. If you have high level of IAP, you will not develop type 2 diabetes. But if you have a low level within those I just mentioned, then you will develop type 2 diabetes. We have done the mouse study, we have done the human study, but we need a clinical trial to prove it. And that's why I am coming to all of you for your help.
That's terrific. And what I get from the discussion that we've had is that really you're talking about data capture. And with that, I'm going to ask Marcella a question about the data, because your organization basically traps A1C levels, and you have this continuum of data that you feed both clinicians and patients and health departments. And then you also incorporate data from the social determinants of health. And so can you speak to what that data management, capture, delivery, what that does to the care management?
Sure. So what we do is we take the data, and I'm going to give you a story because it's easier for you to understand it. We had a patient that brittle diabetic. Her son was a type 2 diabetic. She was going to the food pantry every single day. So we're connected with the food pantry. And what we would say to the food pantry is, after we saw it, she was going to the food pantry for 7 days in a row, we notified the food pantry and said, something's wrong here. You're giving her this amount of food and she's going to the food pantry every day. We're going to notify her physician. We notified the physician. Physician said, well, her panels are really off and her son is not taking his insulin. So we said, okay, so what's going on? We went back to the food pantry and said, can you give us some more data? What kind of food are you giving her so that we can notify the doctor? They said, well, because she has the 2 kids, we give her the bread, we give her the milk, we are giving her some vegetables. But the food pantry said to us, but we never asked her, did she have a place to put her food? Did she even know how to cook it? So when we found this out, we went to her environment. So this is where social determinants of health really helped to put the pieces together for this patient. Went to her apartment. We found out that she was in a rat-infested apartment, heavily mold. So whatever they were giving her from the pantry, the rats were eating the bread. She had no refrigeration because the refrigerator didn't work, and she didn't know how to use a microwave. So we were able to place her into a different setting, even though she had housing. I always tell people, just because you have a housing doesn't mean it's the appropriate housing. We put her in a setting where she could have refrigeration, she had a place to cook food, and I was so excited when they told me, they said, Dr. Burden, guess what? That patient you were so concerned about, her numbers leveled off, and her son has no signs of diabetes. So that's where social determinants of health and the data we collect helps the whole health continuum.
You were also telling me the other day that you can look at very tightly boxed geographic populations, and you can look at the kinds of stores, food stores they go to, and if somebody is living in an area with a lot of fast food, pizza places, your organization will work with the state and give financial incentives to help them change their menu so that the menus are more healthy. Likewise, you went to Trader Joe's and you saw that Trader Joe's was underrepresented in these areas, and so you passed a bill that provided a financial incentive for Trader Joe's to put more stores in. Is that correct?
That is correct. So what I do is I go around the communities, and we go to the social economic communities with the lowest, I would say the lowest access to care. And just because we say access to care doesn't mean they can't go to the doctor. It's just that the access is not culturally compatible for them. So we also went to the stores, and in certain neighborhoods in New York, there's stores. New York is famous for its delis. Everyone likes that egg and cheese. $2. Well, it's not $2 anymore, but it's $2 egg and cheese. Everyone loves that. But there was no grocery stores there, nowhere to get fresh food, fresh vegetables. So what I do is I go around to neighborhoods, and people I work with, they hate to hear me talking because I talk about health disparities and I talk about health equity. I know I can't say equity anymore, but I talk about health access where people can't get the kind of vegetables that you and I are used to, fresh vegetables. Even frozen vegetables is better than canned. And what I do is when I find these areas, I go to the state. That's why I'm VP of Government Affairs. Go to the state. I lobby with my congressmen and my senators, and they hate to see me coming, and I said, we got to pass a bill. And I guess they pass the bills because they're tired of me talking to them. But it's actually helped a lot with places like Trader Joe and Whole Food, because the state is giving them tax abatements to actually put their markets in places where they normally would not be.
You know, actually, Dr. Chalamet made the point when we were talking that Amazon, as it relates to underserved areas, has created a whole series of online provisions for the delivery of healthier food. And they've created payment models for people to do that. Do you know much about the Amazon?
Yes, so Amazon, we use Amazon especially for our seniors. So we give them a Amazon allotment where they get fresh farm foods that are sent to their home. And there's also a new place in New York, it's called Rethink Food, where they will take these foods and they will make them culturally compatible for them. So, because most people say, well, I want my rice and beans. Well, you can have rice and beans, but with cauliflower. And we use Amazon and Rethink Food to do that for our seniors, and especially a lot of the newer immigrants that are in New York.
That's terrific. Now, what I want to do is go back now to something that you were saying earlier, Amy, and that is when you look at the delivery of primary care, and you know, we can say to people on Medicaid and other places that are underserved, you need to eat better, you need to do these things. The challenge comes first with a health literacy issue, because they don't have it. And that begs the question about, well, what is their primary care physician and primary care team doing to help them? And you had said that, you know, a lot of people walk around with chronic conditions that are not really serious, or they're developing, but they're not life-threatening yet. But without having some kind of data and awareness, then an acute event occurs, and now the horse is out of the barn, and so on. What I'd like to do in the portion of our discussion left is really, how do we adjust primary care design so that we can apply population health management tools to improve one-to-one primary care for people and give greater access to more people. I have some thoughts, but I'm just curious if we could just go down the line, what you guys might think about how we might do that.
Sure. So the average primary care visit for an adult is about 15 minutes in the United States. And that includes reviewing your labs if you've had them drawn, refilling your prescriptions, really no time for preventative care at all. So there's different models. People go to functional medicine physicians for primary care, different types of physicians for primary care. I grew up in Detroit. We were not wealthy. We went to the doctor when our bone was sticking through our skin or something of that sort. And talk about a food desert, it's certainly gotten worse over the years. And one of the problems with primary care physicians is you don't have a lot of talk about prevention because nothing's a crisis until it becomes a crisis. And then you have the question of, is the primary care even giving good information? There are good doctors on bad days, there are bad doctors on good days. But since I think storytelling is actually a really very effective way of telling this, I had a patient the other night, and I've HIPAA compliant, of course, and I told her, I need to tell your story because it tells you about health literacy, not in patients, but of physicians, in that she was an insulin-dependent diabetic, very well controlled her entire life. And she came in with a blood sugar well above 800, diabetic ketoacidosis. What has changed? Well, she got a new doctor, and her doctor said, you're not eating enough fiber. So why don't you have some apples? She said, okay, well, how many apples? Well, you can have up to 10 a day.
Keep the doctor away.
And I rarely believe patients. I'm a night shift doc, but this woman was sincere. So she had apples, about 10 a day for a week. Ended up in the ICU, kidney failure. She developed a cardiomyopathy, her heart enlarged and didn't work as well. She's going to have $80,000+ worth of debt that she didn't need to have, and progresses her neurovascular and cardiovascular health down a road she didn't need to go because the doctor was like, you need to have more fiber. And it's not because the doctor doesn't care, he just sees one part of the issue. Whereas if we look at patients as a whole, from the social equity, you know, even having a Trader Joe's, can somebody afford to go to Trader Joe's? I looked at Trader Joe's the other day. It's super expensive. They're very nice, but super expensive. It's, if someone has $5 to eat, it's easier to go to McDonald's and get something processed, which is going to cause more harm than going buying a bag of apples, which if you're not a diabetic is not a bad thing to have. And so finding people who attack it from all different sides, preventative, dietary, education, pharmaceuticals, which I don't mean to demonize, but they patch a problem that we have to fix. So that is not just more primary care doctors, but primary care doctors who can take the time and who are educated as to fixing the underlying cause.
And at the beginning, what you just said is that the average physician can only see a patient for 15 minutes.
15 minutes.
For the doctors in the room, you all know about RVUs, relative value units. Adam, we were talking before about how do you create the value proposition and how do you work with the payers in order to adjust the system so that the doctor can get what should be properly redeemed, or how they should be redeemed properly, right?
Yes, we were. But let me answer that by stepping back a little bit, if I could, because I just want to build a little bit on what Amy was saying, and then I promise to answer your question.
No, that's fine.
Because I think what Amy was getting at is there are a number of, and what you're getting at is there are a number of fundamental issues. One is the whole pay structure. Another is shortage of primary care docs. But I'd even start with health literacy in general. And so, you know, it's easy for us to sit up here and say, hey, everyone should eat better, and everyone should exercise, and everyone should manage stress, and, you know, but how do we really do that? And it can be very confusing. I'm going to tell a story. My wife's in the audience, but I'm going to still tell a story about my father-in-law, who passed many years ago. At one point, you know, he was the classic smoked, and then he was told by his doctor, you got to quit smoking. He worked for Mack Truck his whole life and spray painted before he even wore masks, so he started developing some lung disease. So he committed to stopping smoking, and then, of course, put on the obligatory 40 to 50 pounds after he quit smoking. Again, this was 25 years ago. So he had a nutritionist through the VA, and he was trying to get more educated. But I remember I walk into the kitchen one day, and he was eating, I think, what were they called, Snackwells or whatever, those cookies that used to say low fat right across like the, and the healthy cookie. And I remember I walk in and I go, and I knew, like we had just talked about, he was going to really try to eat better. And I go like, Dad, what are you doing? And he goes, what? It's low fat. And I just took, like, they used to have one of those old-fashioned sugar jars, you know, in the kitchen. Like, old-fashioned, but we don't have as much anymore.
Right.
We don't have one. And I went, he had one of those, and I went, Dad, there's no fat in that, but would you eat it? You know, and so health literacy needs to happen. We need more primary care physicians. But when it comes to the reimbursement model, I would say a couple of things. And this may be controversial. For a lot of what we need, I don't know that the physician is the right person to offer it. There's not enough of us, certainly when it relates to primary care. Quite frankly, we're too expensive. And we don't get educated on how to teach someone how to eat right, how to motivate someone to exercise, you know, other things. I mean, you can hear, even looking at some of the social determinants of health. I mean, you get a lecture or two in medical school, but you're not really an expert. You don't really know how to intervene or even often, you know, implement or connect people to services that know what to do. So it can be very challenging. I think there is, within the diabetic world, certainly an opportunity. This is something I've been working on quite a bit lately for our company, where we have a probiotic that actually is approved and been studied in clinical trials to treat diabetes. So I've been working on this RVU model, and not RVU, excuse me, value kind of model for it.
Yeah.
And the reason I think there's an opportunity there now is because so many payers and self-insured entities are spending so much on the GLP-1 analog drugs, and they are desperate for solutions. And of course, and some of you may have diabetes management companies, some of you out in the audience, you know, I think they've been around for a while. I think they're very, very important and a piece of the puzzle, but I think there's an opportunity here to really push the concept of prevention and ideally keeping people off of these very expensive drugs. So I think that's one piece that really relates to the way we can look at the value proposition nowadays. And just a final comment is, I also think, building on what I was saying about the physician maybe not being the right individual, that we need someone else within the healthcare system who can offer this. From my perspective, I think it's a health and wellness coach. These are individuals who are trained in behavior change, trained in motivational interviewing, are typically not expensive, certainly compared to physicians or nurses or others, and are really more specifically trained to offer people guidance, to connect to what people's goals and motivations are, because often, you know, simply just educating isn't enough. You need to understand what is behind, what really motivates someone. What's really going to motivate them? And it isn't necessarily to try to keep their hemoglobin A1C but below 6.4 or something like that. I mean, that isn't necessarily what's going to motivate them. It may be, I want to be around for my grandkids. It may be, I'd like to be able to walk with my spouse and not be short of breath. I mean, it may be, you know, I don't want to die of a heart attack at 48 the way my dad did. You know, there are ways that we can get at that through motivational interviewing, and this is what health coaches can do very well. Mm-hmm. A related piece to that is, I think one of the challenges there has been scalability, and that's where I think it's very interesting to see some companies that are integrating sort of digital coaching platforms, AI, as a way to make the approach more scalable and still have that same outcome.
That's great. So what I'm hearing you say is almost that by incorporating multidisciplinary teams, you can change the workflow so that the data gets captured by different people, and as long as the electronic records, you know, can be connected, so you don't have silos of data, you can have everybody looking at the patient, and so the data is becoming more forward-looking about where you're going to be going, and that's where your social determinants of health become so important, because you have not just theory about what will happen to people. You actually have data that says, if your profile is this is what will happen to you. There's a woman I know, formerly from the University of Michigan. She's an epidemiologist, and she studied through University of Michigan the 6 million people in Detroit and other areas, and she said, we got it down to an absolute certainty in our advice to people. So I think your point is really well spoken about getting these disciplines together. And I think it does beg the question, ultimately, for all of us to ask the, I'm not sure I call it the medical community or the healthcare delivery system, to re-examine holistically the way primary care is administered so that we can hit triple aim type metrics. Now, one thing that's interesting is I'm consulting to a company in Australia called Ipsium, and they're in a prototype and they're doing early clinical trials. They've taken allied health professionals and married them up with physicians to create, so they do like a health risk assessment to get a profile of the patient. And then the patient goes into these 10, 12-week programs to learn about their health. And then they develop a buddy system in these peer groups so that the AHP becomes the guide. And then from there, the teams learn how to hold each other accountable. Now, from a revenue perspective, what's fascinating is there's a referral system he's created so that the doctors who do this get paid more because typically, as you may know, there's a 3-month waiting list for some of these care services. And by virtue of the way they leverage the allied health professional, they can triple, quadruple the number of people they can see, and they get paid on all of them. So it's sort of an interesting model that he's very early in it, and they're trying to bring it to the States, and we'll see how it goes. But so
Can I just make one follow-up point?
Yeah.
Because I think you
Yeah.
and I had discussed this. I'm now realizing the whole audience may not be aware of it. I mean, you might think that don't all the insurance companies want to pay for prevention? Doesn't it make more sense to prevent the development of diabetes than have to treat it and all the downstream costs of everything from cardiovascular disease to surgeries and the kind of risks that diabetes? And the answer, and I saw a couple of heads shaking no, the answer is no, and by and large. And the answer is no because, again, not in your world maybe so much, but in the typical world of a Blue Cross Blue Shield or United or Aetna or what have you, they're only keeping the average customer for 3 years.
right.
So it doesn't behoove, and certainly doesn't behoove that CEO who may be worried about the next quarter, let alone 3 or 5 or really 10 or 20 years down the road, what the cost of that individual may be. It doesn't really behoove them to cover as much of the preventive approach today. And that's where I was going with this whole until GLP-1. And then there's maybe an opportunity here within diabetes because they're spending millions upon millions of dollars. That's only projected to increase. I mean, 13% of the population at the moment is on a GLP-1 analog drug, and that's expected to continue to increase dramatically. And of course, the cost of those drugs. I think there is an opportunity here to look at that in a different model, in a different way. But
Great, thank you. So I'm going to have one final question for the panel, and then we'll open it up for questions from you all. Great, thanks. If there's one point that you would like to leave for the group, each of you, what would be the one thing that you would say, okay, when I went to the Health 2.0, I went to that panel, and these are the 4 points that I got from it. What would you each think about?
For me, it comes down to it's simple, but it's not easy. If you can't pronounce it, don't eat it. If it has more than 5 ingredients, don't eat it. If you have to pull money out of your wallet knowing I'm going to be pulled out of the workforce if I don't fix my diabetes, I'm not going to be able to have sex and have babies because I'm going to be impotent. I'm going to have a stroke, I'm going to have a heart attack, and I won't see my kids grow up because that bag of chips is way too important to me than my kid. If I knew that I was going to have to make a choice between feeding my kid and taking my diabetes medicine, because there isn't somebody like Arcella to help me with those things, knowing that you don't have to spend $15,000 average out of your pocket for your diabetes medications every year, maybe that'll help you make the simple choice. So simple, but not easy. That's my take-home point.
That's terrific. How about you, Adam?
Well, I'll make a very focused point, which I think is whether you're a healthcare provider or, as most are in the audience, non-healthcare provider, you may not appreciate the impact that the microbiome has on overall health. I think it is the next great frontier of our understanding of human health. And I say that because it's an area that we actually can intervene as a healthcare provider or as an individual. Now, it's often through doing the things that Amy was just talking about, but maybe that's a takeaway for some of you that will be a new thought, that the science around the microbiome and how it's influencing everything from the development of diabetes to the development of Alzheimer's to various cancers is one of the next great frontiers of healthcare and something that's worth learning more about.
Great. How about you, Arcella?
I would say for all physicians out there, and even people who are not physician, you probably heard the saying, don't judge a book by its cover. You got to look in the cover. That's where social determinants of health come from. That's where putting the whole person as the center, going back to patient-centered care. And don't think that just because you told them that they understand what you're saying. I think that we all have to look at people as individuals, not as a statistic. And that's what I have to say.
Terrific. And Biplab, how about you?
Okay, this is totally new, I believe. One thing, that's intestinal alkaline phosphatase deficiency, or IAPD. IAPD will govern the next century for chronic inflammation. For all those healthcare provider, that is the news. Thank you.
And so actually, to your point, it's not just about diabetes, it's about any chronic condition that develops from inflammation.
Yes.
Beautiful, okay. Well, I want to thank the panelists for your wonderful thoughts, and then I would kind of open up the floor to anybody who has a couple of questions. We've got probably 5 or 6 minutes left, is that right? Okay.
12.
Well, it says 12, but
Oh.
he came over when it said 16 that we had 10. So.
Okay.
Yeah, go ahead. There's a microphone right here.
Just a quick question, Dr. Perlman. What's the name of the probiotic, or the can we?
Of course, so the name of the company is Pendulum Therapeutics.
Uh-huh.
And I'll give you the website to make it easy. It's pendulumlife.com. But the one I was referring to is called Pendulum Glucose Control.
Okay.
So that's what has the akromansia in it. We did a 2020 randomized control trial that looked at type 2 diabetics on metformin that showed improvements in hemoglobin A1C and glucose. And again, all through these mechanisms that I was only scratching the surface on.
Okay.
But yeah.
So metformin is actually influencing the microbiome.
Metformin also has an influence on the microbiome. Actually, there was a study, I haven't even read the full paper yet, it just came out this week looking at the role, but we do know and do understand that part of the mechanism of metformin is an influence on the microbiome. But this was, just to be clear, the probiotic I'm just mentioning, this was people, type 2 diabetics on metformin who were suboptimally being controlled. We added in these unique kind of next generation probiotic strains through this Pendulum Glucose Control product and saw significant improvements.
Thank you.
That's great. Somebody have a question? Yep.
I have a question. We talked about the role of, let's say, the producers. We talked about microbiome, about Wegovy and so on. But what about the role for the government? I'm from Switzerland in Europe, and many countries in Europe have introduced a sugar tax in the previous years. And they have seen this has very good effects on even, let's say, the incidence of obesity, overweight. It's good for dental aspects, but it's something for the government. So what do you think about this? Could this be done in the US also?
I'll make a quick comment, then I'm going to look this way, because this is, so if you look, and again, this is association, if you look in the US at incidence of obesity in the United States, there is a direct correlation with obesity rates were kind of going like this, and then it was right around 1980s. In 1980, you see this, and interestingly, it corresponds to the farm bill that subsidized corn and the introduction of high fructose corn syrup into the US market. I mean, it's amazing to see the way the curves parallel. And so certainly in Europe and other countries, I think there's really interesting experience in sort of what we might say in the habit formation word, adding friction to eating unhealthfully by either making it more expensive. Similar thing too is with cigarette smoking. So in the United States, what they did do is, and people may wonder about this, you ever wonder why when you go into a gas station, you have to ask the attendant to buy cigarettes? Hopefully none of you smoke, but if you did, you know, you might say, well, that's because you have to be over 18 or whatever the age is. No, they have alcohol in the refrigerator. They just bring it up to the counter. The reason they did that from a public health perspective was to add friction, to make it just a little more difficult. So you had to go and ask someone to get it off a shelf and make it more difficult to then be a smoker. So certainly we've done some of that, but why don't I turn to any of my colleagues, maybe yourself, but if there's more. But thank you.
So I'm going to weigh in on this. What we try to do is have government help people here in the States and not deter them. So one of the things that we're doing in New York is we are deterring them. We have a ban on the vapes and the flavored vape, so you can't buy that in New York now. What they're doing now is, and this is one of the things that I can say that I actually helped do, is to stop with the sodas, selling those little cheap sodas at the store, at the deli, where they're $1. So there's no more sodas. So now you can have juice. There are some places that will still sell them, but it's really a ban on the sugary sodas. And we've actually lobbied the beverage community to reduce the soda. I know you may have seen where Coke Zero has 0 sugar and it tastes like the same Coke. So this is something that we do to lobby to get people to be healthier, because I will tell you, one of our old commissioners of health said, people don't know that they're not eating healthy unless you tell them.
And in regards to the corn, as you well know, in Europe, the crops are very different than the crops here. But also with the processed foods, in regards to corn, the number one user of corn in the United States is, people don't make corn muffins out of it. It's used to essentially for ultra-processed foods. In regards to the things that are killing livers, so non-alcoholic fatty liver disease, it's fructose and glucose. It's not fat, it's not alcohol, it's fructose. And when you look at corn and soy and the industrial solvents that make up our food, Diet Coke is, to me, it's even worse than Coke, because at least Coke is sugar. Okay, sugar is horrible, but now you're adding sugar alcohols to it, which directly affect liver processing. It affects the microbiome, all of those sort of artificial sweeteners and things. So if corn was just corn, no one would have a problem with it. But corn isn't just corn in the United States, unfortunately. It's corn syrup and corn starch and all the things that are, again, directly causing diabetes.
I mean, I would say you kind of emphasized the point that it really does. I mean, you went back to it kind of takes a village, your comment earlier, with the healthcare team. I mean, issues like what we're talking about, whether it's sort of the obesity/diabetes epidemic in this country, worldwide, et cetera, it does require the healthcare systems, the political systems, you know, to really come together to ultimately tackle the issue.
And I just want to piggyback on that and say that when we talk about corn and fructose, you have to understand that's economics. Mm-hmm. And you don't want to mess with economics. People make a lot of money on it. So when you want to have this battle, you have to pick your battle to fight. So one of the things we did was we said, let's take all sugars out of Coke Zero. Let's take all of it. We don't want any more of the artificial. Just have it natural flavor and see if people like it. And that's what they're doing now. So they're taking all the sugars out. Unfortunately, it's not selling that well, but I will say I can see a difference in people if they're on a diet. Instead of having that artificial sweetener, get a Coke Zero if you must have a Coke. Get a Coke Zero. Yeah, but it doesn't taste like anything. Yeah, but try it.
Thank you. We had one question, but I'm getting the hook. So why don't you come on up and we'll answer your question offline. And anyway, thank you all for listening, and thanks to the panel for great discussion.